direction. Normal is 12 millimeters. 12 millimeters is merely a half an inch. If a patient can't move his mandible a half an inch to the left or a half an inch to the right, you should suspect that something is wrong. When we palpate around his head in all the structures, no muscles were in spasm. Why would there be no muscles in spasm? Usually there are. The reason is he's a flaccid paralytic, and the muscles don't work correctly. None of them are in spasm on the examination. This is his history that he gives of his symptoms. Migraine headaches, much neurological testing. His medical file, he states, is several inches thick. He has trouble walking, and which most of these movement disorder patients do have. He has mental confusion, can't remember anything. He's been classified as learning disabled since very early childhood. He's had orthodontics from 14 to 16 years of age, which is relapsing. He's had 4 bicuspid extractions. He's had cervical headgear, and his maxilla is over-retracted due to wearing the cervical headgear. This is his cephalometric X-ray showing the antigonial notching in front of the gonial angle. He also has a constricted airway, which you can see posterior to his palate. His frontal X-ray shows occlusion of the nasal fossa with overgrown turbinates. So therefore, this patient has 4 strikes against him: an obstructed nasal airway, an obstructed pharyngeal airway, which you saw in the previous slide, C-spine degeneration from the previous slide, and a non-functional hypoglossal nerve. His left condyle is supposed to be nice and round, about the size of a dime, and you can see it's bent forward and comes to a point. His right condyle is flattened off and comes to an osteophytic point on the anterior superior surface. Here is a close-up of the right side, eccentric occlusion. This is not a normal condyle. You can see its outline here, coming to a point and then back. This is the left side, wide open, which you would suspect at 55 millimeters interincisal opening, where the condyle has come past the eminence right here and is separated from it. This is his occlusion from the right side, showing that the orthodontic result is relapsing. This is the occlusion on the left side. It's a little better, but still relapsing. This is the splint that the patient was wearing when he presented to my office. It's a little teeny-weeny splint that people make to put on the back teeth to eliminate interferences, because they think interferences cause muscle engrams, which causes the pain. As you can see, it wouldn't do a bit of good in this patient's case. It's very harmful, in fact, because it's the wrong design. You put that little splint in his mouth, and his mandible goes posteriorly, increasing his anterior overjet, or protrusion of his teeth. When you take it out of his mouth, the protrusion of his teeth lessens, so the splint is causing him harm and making him worse by posteriorizing his mandible. On the left side, you can see the harmful version of the splint posteriorizing his mandible, worsening his osteoarthritic degenerative problem. On the photo on the right, without any splint, the patient's body repositions the mandible downward and forward, decompressing the tissues of both joints. This is the repositioning splint we used. It is a highly indexed splint where the patient can bite in only one position. This is what it looks like out of the mouth. Here he is opening 54 millimeters, and you can see his tongue is already getting better on his left side. This is the patient at the end of treatment, and you can see his mandible has been repositioned in an end-to-end position. This is centric relation with the disc in place. And now the second stage, and there is always a second stage to address the occlusion of the teeth, is fitting the teeth together on the sides. We do this again with a maxillary expansion appliance to accommodate an advanced mandible. put teeth on the upper arch and level and align the teeth. On the lower arch, we put composite buildups and brackets on the rest of the teeth and level and align them. We put a molar tube on the second molars as high up as we can, even if it's on the composite buildup. This is the patient at the end of stage 2 orthodontic treatment. Can you see a difference in his tongue now? When you correct one thing, usually the other things that he has wrong with him self-correct. This was him before and after. You can see the difference in his tongue right away. This is his condyle at the end of treatment. If you remember how it was originally, it is more substantial and bulked up now. This was it originally, and see how thin and narrow and tapered it was at the end. This is a comparison before and after. The condyle is much more massive now than before. This is the right condyle after treatment, showing that it too has changed shape. This is the right condyle before treatment, showing how flattened it was at the top and coming to a point on the front. This is the before and the after of the left and the right sides. You can also see that the glenoid fossa has more definition, the eminence has more definition, the condyle is bigger. Everything is better afterwards than before. When making tracings of the left and right sides before and after treatment and superimposing them on the intervascular bundles on each side, we can look up and see the increase in height in the condyles, and it has increased approximately 3 to 4 millimeters on each side, at least 3 millimeters on the left, and possibly that much or more on the right. Okay, this is his left side wide open before on the left side, and afterwards on the left side. And the right side is before on the left and after on the right. This is the patient as he came in 6 years post-treatment. You can see the improvement in his tongue is holding, the inner incisal opening is holding, everything has been stabilized at this improved position, and he is now off welfare and working and is contributing to society. These were the x-rays that we took at that time, 6 years post-treatment, and you can see the improvement in the condyles are continuing to hold. The take-home message from this patient is that only anterior repositioning appliances are capable of making these changes, and they are capable because they mimic normal mandibular growth. This is the anterior repositioning appliance. This is normal mandibular growth, where the weight of the mandible distracts it from the base of the skull, and it tends to grow back in the direction the arrows are pointing. Parkinson's disease is due to decreased dopamine in the brain. The symptoms usually begin on one side of the body. It often begins with finger or hand tremor. There is slowed movement or decreased ability to move. The steps become shorter. There's difficulty getting up from a seated position. They have a stooped posture, balance problems, muscle rigidity and stiffness, decreased ability to blink, smile, or swing their arms, low, slurred, or hesitant speech, and handwriting changes that appear small and difficult. We're going to begin with this Parkinson's patient. She was first diagnosed with Parkinson's disease 13 years ago. Her main complaint is she cannot walk and her body, quote, freezes up. Her eyes water frequently. Another big problem is constipation and flatulence, which she describes as severe. Her left arm contracts uncontrollably with motor spasms. She's got loss of her right arm motor skills. She's got obsessive compulsive disorder and anxiety attacks. She can't concentrate and has difficulty speaking. She happens to be a nurse. She suffers from depression. Her body gets very hot. She has weird dreams, chronic fatigue, and insomnia. She has right back and hip pain. Current meds are levodopa, Mirapex, and sleeping pills. Her TMJ report, which we take on every one of these patients, shows her right disc is medially displaced. She has severe loss of equilibrium and vertigo problems. She has bilateral TMJ clicking upon mandibular protrusion and painful to chew, difficulty swallowing, stiff necks, cervical crepitus when she moves her head left and right, inability to turn head to the left or right, bilateral shoulder pain, tingling, and numbness. This is Rose, a patient who presents with Parkinson's disease. She has been seen by 3 or 4 neurologists, right?
Yes.
And you've been examined by Johns Hopkins University.
Yes.
And they've all diagnosed you with Parkinson's
That's
disease.
Correct. Yes.
Tell the audience some of the symptoms you've had.
I have freezing when I'm walking. I have, when the medication isn't working, I just can't walk across the room by myself. I have to hold on to things. I'm very weak and get fatigued. I have slow speech with just fine motor movement problems, not able to wash my hair or brush my teeth or anything like that when the medication's not working. Little, very small writing where it's ineligible, it's not able to be read. Teary eyes, not able to speak. My cognitive level, I'm not able to actually function or focus on anything. Rigidity, my back is very rigid and sore. I get a lot of low back pain. Contractions, muscle spasms. My feet contract. My toes will crunch in and just flare out. Just a lot of spasms, muscle spasms, involuntary movement. I have some face pain too, facial pain, tingling in my shoulders.
How many years ago did this begin?
It's been about 13 years that it's all started.
13 years?
13 years ago, yeah.
And what age were you at then?
About 47.
47, okay. And has it been getting worse over the past 13 years?
Well, the medication, at first, it just took all away my symptoms. I guess it's been really, the last 3 years, it's been just progressively getting worse. And then last year, I actually had to take off work and go on disability.
So the medications is not as effective now. It's losing its effectiveness.
It's losing effectiveness. It doesn't, like yesterday, it didn't work at all for me. I mean, I was just off all day long.
We are delivering the appliance now and putting in articulating paper to determine if one side is higher than the other. The patient indicates that her left side is a little bit higher than her right side. Okay, just sit there for a while. This is Rose, our Parkinson patient, who's received her appliance 6 days ago and has been wearing it ever since the last 6 days. And I'm reviewing her symptoms that she came in with, and we'll go over them one by one. She'll tell you about her ability to walk, whether or not that's improved. Why don't you?
That has improved a little. I don't feel like I'm as off balance as I was before.
Okay, that's an improvement in her balance. And she was saying her toes would claw up.
My toes would claw up, and that is less than that. It's less. Usually I would have that every day, and now I think I've had like a couple times since I've had the appliance in my mouth. Okay.
She was constantly constipated. And tell them what happened there.
Yeah, I was constipated awfully, and I know since I got the appliance, I've been going regularly every day now, which was never for me.
And what did you go before? Every 3 days, 4 days?
I go sometimes every 6 days.
Well,
and then I have to give myself an enema to actually, to be able to go.
Well, that's a big improvement.
That's a very big improvement. I was shocked.
Okay. And you had the loss of motor skills in your right arm and constant contraction of your left arm, and that's improved somewhat.
That's improved somewhat, yeah.
Okay. And your anxiety attacks that you used to have, how frequently did you used to have those?
I used to have them once in a while. I wouldn't frequently have them a lot. I would have them like maybe a couple times a month. But, but I haven't felt depressed or anything this week.
No depression, okay. Weird dreams, you used to have weird dreams?
Still have some dreams, but they're not as horrible as they were before. They've been nice dreams, actually.
And depression?
I don't feel like I've been depressed all week.
Well, those are pretty good improvements for just 6 days into treatment.
Yeah, really.
What we're doing today is modifying her appliance to compensate for any wear that she's had in the 6 days, and we're increasing its height to take additional pressure off the base of her skull. And we're going to, her appliance is in the laboratory right now hardening up in a pressure cooker, and I'm going to go back and retrieve it and fit it to her mouth and polish it up and discharge her for the day, and that's going to be her entire appointment. Rose returns after wearing her appliance for 13 days. She's been wearing it constantly and has been experiencing good results. She reports that her constipation has disappeared and has gone from a bowel movement every 6 days to becoming regular, at least daily or at the most every other day. Her concentration is better. Her dreams have gone from weird to at least pleasant dreams. Her experiences with her body getting very hot have gotten better. Chronic fatigue is better. She gets more done during the day. Her depression is better. Her anxiety attacks are less frequent in spite of much stress at home. Why don't you comment to the viewing audience how the past 13 days have been?
Well, it's gradually gotten better. Before I had the appliance in, my medication that I take for the Parkinsons was not working. I had more off time than on time, which left me rigid and a lot of back pain, and that still a little bit. I get that with the medication, but not near as often. My balance is a little better. I have more on time with medication, meaning I don't have all the symptoms of Parkinson's that I did before. Depression's gotten much better, and like the doctor said, before my constipation was off, I would have to give myself an enema to go. Now it's just like, it's changed. It's like more, just better, more frequent, and which makes me feel better. And all that, I'm just feeling a lot better. My fatigue's I have more energy during the day. I'm able to do things like before. I couldn't go to the store without being afraid the medication would stop working, and I'd be in the middle of a grocery store and just like be rigid and a lot of freezing, and I don't have that fear anymore because I'm feeling better. So it's amazing.
That's a good first report, and I'm pleased with the patient's progress. We're modifying her appliance today, increasing the vertical dimension of it, and we'll show you that as soon as it comes back from the laboratory. Okay. Chop, chop.
Yes, I tried mine.
Okay, bite. Open. Okay, bite again, bite. Open. Okay, you can stop. Okay, chop, chop. Okay, which side's high now? The right side. Chop, chop. Bite tight. Okay. The right's still high.
They're the same now.
They're both even? Okay, bite. Bite. Okay. Okay, this is the of the appliance that we are going to leave the patient with at the end of this appointment. And we'll see her in another week or 10 days and see what the improvement has been. over and above what it already has been. Okay, this patient has returned. She's been wearing her lower appliance for 1 month and 5 days. We completely rebuilt it today, and this is the end of today's appointment. Overall, that you're doing
Better, definitely better.
okay. This is this patient's frontal x-ray. You can notice that the mastoid processes of her temporal bone are not equally aligned. This one on the right side is caved in and closer to the midline than is the left. These temporal bones contain the glenoid fossas, so you can see that the glenoid fossas are not lined up symmetrically either. This is the probable reason why the disc on the right is picked up as being displaced by the MRI. You can also see that she has a deviated nasal septum right up here. Evaluate the nose for whether it's obstructed with overgrown turbinates or it has a nasal airway present. This is this patient's submental vertex x-ray. You can see that the mandible is not centered in the base of the skull, but is off to her left side. You can see the space between the right side of the mandible, which is right here, and the right side of her head, which is right here. And you can see that it is inset quite a distance, whereas on the other side, it almost is superimposed on the outside of her head. Also, you can see that this side of her head is more normally rounded than is this side, which has been flattened. All of these are cranial compensations to the displaced disc. This is this patient's Panorex x-ray. You can see that she is missing 4 third molars as well as 4 first bicuspids. This is in keeping with her history of having had 3 years of orthodontic treatment. This is the patient's lateral head x-ray. You can see she has a fairly substantial airway right in this area. This black shadow is her airway. You can see that she is suffering from suboccipital decompression of the tissues here at the base of the skull. There should be a 14 millimeter gap between the base of the skull and the first cervical vertebrae. This patient was diagnosed with dystonia and myoclonus. She's had migraines with aura all of her life, occurring all day long. She's had tension headaches up the back of her neck and head. Her whole body tremors and twitches. She's got bilateral arm numbness, left arm worse than the right, throat constriction, history of otalgia as a child. She's on medical disability leave since 2007. She also complains of headache with left face pain, photophobia, bilateral tinnitus. She complains of bilateral preauricular pain, left side worse than the right, bilateral arm numbness, left side worse than the right, bilateral TMJ crepitus, right side worse than the left. Her mouth locks shut, inability to move her mandible to the right, painful to chew food, difficulty swallowing, bilateral suboccipital pain, neck and shoulder pain. Her previous treatment consists of seeing 5 orthopedists or neurologists for back pain. She's had microdiscectomy and laminectomy. She's had chronic pain management, multiple nerve blocks and facet joint blocks. She's been to see 2 different headache specialists. She's had acupuncture and biofeedback. She's been to see a movement disorder specialist and multiple physical therapists, which she describes as 6 to 7. The medications she's on are Flexeril, atenolol, clonazepam, Scalaxin, Percocet, Maxalt, Seasonali, Zoloft, Dionex, and Lodine. These are tomographs through the patient's right temporomandibular joint in centric occlusion. You can see where the condyle is located posteriorly in the fossa. It should be at least centered in the fossa or slightly anterior center in the fossa. This is initial tooth contact, showing the position of the condyle in the fossa, and this is bite tight. You can see that the posterior joint space, or the behind the condyle, is diminished from the initial tooth contact to the clenched position. This means this patient has a distal skid from initial contact to bite tight. There is not supposed to be any distal skid. There should be no change in these two images in either the left or the right temporomandibular joint. So we can tell just by looking at the images that her occlusion is not correct. This is the patient's submental vertex x-ray, and you can see the mandible is not centered in the base of her skull. In fact, it appears a little bit cocked to one side. We take this view with the mouth wide open so we can image the first and second and sometimes the third cervical vertebrae of the patient. You can see that the lateral process of C1 lines up with the lingual cusp of the teeth in the upper arch on the right side, and on the left side it lines up with the buccal surfaces of the teeth, meaning the skull is either displaced to the patient's right or the cervical spine column is displaced to the patient's left. You can see that the foramina through which the nerves go are not aligned properly. You can see that this mastoid process on the patient's right side is much higher than on the left side. This is the initial appointment of a patient who comes to me with gait problems, meaning walking disabilities, and all the typical symptoms of a Tourette's patient. She also has the symptoms of a TMJ patient. You can see in this video she is using a cane. She also described to me that she uses a walker also when her condition worsens. You can see the MRIs of her on the view box in the background. We never, ever initiate treatment without MRIs on these patients. This is the very next day. What we wish to accomplish on this is a diagnostic workup, which means a bunch of very sophisticated tomographic x-rays through the temporomandibular joints, impressions, and possibly her splint delivery. She comes with all kinds of head movements, hand movements, foot movements, and pain. Notice the uncontrolled movements of her hands, feet, and head.
She's holding her head up.
Okay.
Tell us what your symptoms are, so we can record them.
I feel really, really tense all through here, and I can't stop twitching, and my eyes blink like crazy, and it shakes, like the back of my skull almost like shakes.
And how long has this been going on?
Long time.
Years?
Well, I didn't shake like this. I just didn't have until I started screwing around with my mouth TMJ stuff, but I didn't have any motion in my neck, and I would get horrible neck pain and stuckness, like torticollis thing, and migraines. Now those are getting better, but I twitch a lot. If I'm not somehow supported, so I like put pillows under my arms and under my head and stuff, but raising my mouth seems to help stop twitching. I still get twitching sometimes, but not like this bad when I have something in my mouth. And opening it wide hurt.
Constant eye blinking and head twitching are cardinal signs of Tourette's syndrome. Pain upon opening or limited opening of the mouth are cardinal signs of internal derangement of the temporomandibular joint. Many times these patients will present with symptoms of both Tourette's and TMJ, internal derangement. I have had the patient using tongue blades in her mouth to determine what the vertical dimension is.